So I'm a geriatrician, and I want to first of all thank Tan Cheng really. I think this is the first time common CPG, a big CPG like that, includes falls as part of it. And falls has very, very little publicity in Singapore because it's not a glamorous thing. I always tell my dementia friends that, you guys are so lucky. 5% of the population has dementia and you got heaps and heaps of things talked about. And falls being such a big thing and a very common thing doesn't get any publicity at all. So today I'm really thankful that Tan Cheng has given me this opportunity to stand here and talk with you. So as I always say, I will scare people by telling them that falls are terrible. Fifth leading cause of death. One half of fallers will always have falls again. And I think this is actually very common because what we remember just now was that people who fracture again. So people who falls again. All right? So that's the first thing that you should remember. And because I'm a geriatrician in the hospital, I only see less than 10% of people because they come in for fractures. The rest of them will be seen by you. So what are the complications? I think we cannot run away from the fact that anybody who has fallen will have functional decline, immobility, psychological damage. A lot of the people will say, look, I'd rather just park myself in the chair, all right, and I'm not going to go out anymore. A lot of people who are going to church, going to markets, and say, oh, I'm not going to do this anymore, I'm just going to stay at home. It's safer, but it's actually really not true. I think the most feared really is going to be a fractured hip. And because this data is so easily collectible, because obviously a fractured hip is a fractured hip, you'd be surprised too that a lot of my fractured hips walk, all right? I mean, without being fixed. And that's very surprising, but they do that. But a lot of the fractured hips who are fractured in the hospital will be picked up, and this is really one of the worst things to happen. And unfortunately, I always tell the guys, osteoporosis is a woman's disease, they always thought. But I say that if it happens to a man, if a fractured hip happens to a man, they die 2 times faster. So that's really bad news. They're lesser than us, but they die 2 times faster. So just one quick analogy, one of my patients' daughter came, she said, oh, my mom has just fractured her spine. Then the next visit, she said, oh, my father has just been admitted for a fractured hip. I said, oh dear, your father is going to die. And true enough, 1 week later, when I met her in the hospital, she said, my father just died. I said, oh, shucks. So I said, me and my big mouth, so next time I'll never say that again to my patient. So I thought I'll make it really simple for you and simple for myself, and that's how I approach falls. Everybody thinks that falls is very woolly, and so do I actually sometimes until I think about it long and hard. I like to divide it into intrinsic and extrinsic, and I think that is really simple because geriatricians, right, and a lot of publicity about aging. I want to tell you that age-related changes do predispose to falls. All of us will age with eye disease, but I think that one of the things that will happen will be contrast sensitivity, and that's important because we can't perceive depth. So going down the stairs, going into dark corridors, they don't see, they trip. Nervous systems go haywire, and it's worse when there's autonomic dysfunction with Parkinson's, with diabetes. Gait changes, even when we don't talk about any other gait problems like Parkinsonism and diabetic neuropathy, people do change as they age, they walk. And I hope one day we will never see this again, right? Because this elderly obviously not just has a higher risk for falls, okay, she's obviously fractured because she's that way now. So screening, how do we screen? Basically ask, okay, people with falls of more than 2 in 6 months period evaluation, you should really look for a treatable cause. Now certainly a single fall is not really always a sign of a problem. Why? I mean, if there's really going to be a banana skin and you're damn sway, alright, then, if you do away with the banana skin, you probably will get away with the fall, alright? So evidence 1, okay, and there are 4 evidences in the new CPG, and this is evidence 1 which I'd like to put in. Recommended will be that professionals should ask, and that will be you and I, probably you more than me because I told you that there were 4 more in the community. You should ask them about falls. It's all in the CPG, so you don't have to read this one. This one you can fall asleep. The next evidence is that people who present for medical attention because of a fall or report of a recurrent fall or have gait abnormalities should be offered falls assessment. Now then you say, haha, you are asking for business, right? No, it's for you to do it, all right? So falls assessment by people like us, okay, who might only have maybe 5 minutes time in the clinics. Okay, that's sometimes what happens to us as well. What can we do? Basically, look at the person. Time up and go. You'll say, hiya, who is going to take out a stopwatch, right, and time the person? Honestly, if the person is going to take very long time and say, number 31, and it took 10 minutes for her to get into your room, that person has a problem. All right? I mean, besides the fact that she's in the toilet, all right? Okay, but if he or she gets a long time coming in the room, the person has a problem walking. So this is to remind me to quickly get faster, right? Because I know that I'm the second last one, and if I talk any longer, everybody will fall asleep. And my son insists that I put a Tyrannosaurus in. So what are the other things that you may look out for? Cardiac disease, okay? I'm not going to bore you, but musculoskeletal cardiac disease, neurological problems, people with dementia and delirium, people who present as a fall can be really delirious. A lot of my patients who get finally admitted into the hospital are delirious, okay, and they have fallen at home, and the family, clever or not clever enough, will say, okay, there's really something wrong and he needs to come in. People with genital urinary problems, micturition syncope, we had a few recently, people with depression. And then I want to show you this, which all of us probably would be a little bit guilty of. Many drugs that can cause falling. Basically, anybody can tell me what's wrong with this list actually. Everything is wrong, right? Because everything that you have thought about prescribing is there. Okay, so basically, watch everything we prescribe. Everything. We had a woman recently who was delirious. I mean, not pointing fingers. She was really coughing really badly and was given a little bit of Procodine. She was really wonky. And the family said, oh gosh, she was screaming and yelling and falling over. And she came in. And after treating the infection and taking off the Procodine, she was much better. So Procodine, okay, my favorite drug for sleeping. No, I'm just kidding. This list is the one that I like most because, as I said, practicing in the hospital is actually for me more fun because I have a lot of breath to examine patients, to have a lot of time and look for all these small little things that I like to play with. So I like this list because it's something that I really can treat. Okay, sometimes, I feel very helpless when there's things that I can see but I can't treat. So this is something I like. So the next list that I want to show you, another hopeless list, right? I hate falling. Why is this hopeless? Any idea? Basically, it's a head-to-toe examination, to be honest with you. All right, I mean, if all of us have the time, we can do all that. But maybe a take-home tip, okay, which I don't dare to write so that you can't quote me, all right? Well, if I only have 3 minutes of time, I will really look at the person's neurological deficits, all right, and a cardiac examination. I have picked up one or two who had very severe aortic stenosis. So just maybe auscultate the heart, look at the way they walk. If the gait, there's some problem, then there is a problem. So we talked about drugs just now. I think Seokbi has been very nice. She has actually talked about the sedatives, hypnotics. These are the things that can cause a person to fall. Now, this is the second last evidence. Falling treatment for an injurious fall. Older people should be offered assessment. So I keep telling you, right, we've got business, okay? And this is really grade A, level 1. And the last one, people who are assessed to have risk. I copied this straight off from the CPG, only because then you don't have to think. You just read the CPG, all right? Now, intervention should include really to identify reversible medical problems, which I've actually just brought you through. Medication adjustment, which we all know that list, okay? Basically, polypharmacy is not going to be something that we're going to practice. Home hazard assessment, which I think none of us can do, but I'll give you a few tips. Physical therapy and vision correction. And this is grade A, level 1. Just now, we had excellent encouragement for people to exercise. And I think Dr. Leong was talking about exercises. So do you think that walking is the best exercise for falls? I love this worm. He has followed me everywhere. Is it a worm? Sorry, it's a caterpillar. But anyway, any idea whether this is true for prevention of falls? Or yes? Oh, the rest of you are sitting on the fence, I hope. Okay, basically it's false. Okay? It's false. Because if you can imagine this little caterpillar running around, literally, he will trip over all his feet. Okay? And there is actually one paper that says that brisk walking really is not going to cause you to fall more. Okay, so what are the best exercises to do? So remember my caterpillar. Falls prevention, okay? The first one, one of the proven strategies, okay, really is to have muscle strengthening, which we also have in osteoporosis exercises, individually prescribed, okay? So if anybody is trained as a physiotherapist, please go for it, okay? Tell them what to do, all right? Balance exercises, resistance training. So if anybody can do what that man is doing, okay, you are brilliant. You don't have to go for any falls prevention. Inappropriate walking aids. We have a few elderly who are a little bit demented. They use the stick to hit you rather than walk. All right, so walking aids needs to be properly prescribed. You'll be surprised, okay, even I have a problem telling people how to use the walking aid properly. Which hand, which leg to move first, how high, how low, don't trip over the quad stick, that sort of thing. So it took a little bit of learning after so many years before I got it right. And if you ever tried walking, I mean, all of us shouldn't need to, but I had tried playing with a quad stick and truly I tell you I can't coordinate right and left. Okay, so if you all have a problem, then you probably should learn it first before you tell your patients because it was very embarrassing after a while. Environment. I think the motherhood statements, okay, really will be no slippery floors, which like real, right? How to take a bath, right? Poor lighting. I think that one is important because a lot of my elderly, they walk in the dark to the toilet. So I have always told people, please put on nightlight. A small nightlight is actually good enough. Out of reach objects should be actually put within reach. Carpets and rugs, which Singapore doesn't have, right? It's true, right? We don't use carpets and rugs, do we? Actually, we do. Cluttered rooms, walkways, handrails. I think there was a very cute anecdote that this contractor came in and said, I know how to put handrails. We don't need an occupational therapist, which is actually true. If you've actually been taught by the occupational therapist before, or you saw photographs. You know where he put the handrail for the toilet? Behind, like that. So I was like, my patients, the doctor who did the home visit was so shocked. He said, gosh, Linda Hamilton used that, not the patient, all right? So handrails must be placed properly, all right? So I needed so dyingly to show you how a toilet handrail should look like. Okay, it should be at the side and not behind, okay? And this is actually, I always get this to the medical students. What's wrong with this or what's so great about this toilet? Anybody has any idea? Besides the handrails and the non-slip mat, which is at the side, nobody sits at the side, but anyway, the long card short is, what's so great about this toilet? Thank you very much. It's a raised toilet seat. If you haven't seen the old HDB, which my grandmother still has, I mean, if you don't change the toilet bowl, right? The seat is so low, okay, you have to climb the walls to get back up. So if a raised toilet seat is something that you need, then, or the patient's need, then go ahead. What's so great about this bed, besides the fact that it has a little bit of rails here and there? There's this thing called a Jacob's ladder. It's for patients who don't just roll over and drop off the bed, but to climb up the rope, turn yourself around and then get off. So very elegant, but I tell you who would want to sleep on the road, right? But I don't think this is uncommon, all right? We picked it off one of the occupational therapists who had to do a home visit, and this is recent. So a lot of our elderly do have toilets like that or bathrooms like that. So do advise them, soap, be careful, pails, cloth. I mean, basic straightforward instructions, okay? Especially maybe if they have maids who are not so aware, please let them know. And I'm coming right to the end soon. I think footwear is very important, okay? This duck is so clever. He's wearing Nike. Is it Nike? Gosh, quote me. Now, please don't ask them to just go without anything but stockings, because that's wrong. And don't wear slippers. So what I did was, for all of you who want to ask me what is a proper pair of shoes for the elderly, anybody has any idea? I purposely wore one pair, but I won't show you, I'm too shy. So I need to tell you that proper pair of shoes for the elderly would include one that has a heel. All right, so not those slippers, and not those things that, what do you call that? Crocs, right? That's right. Crocs are no good. You need something that is actually covering up your forefoot up to at least 2/3 with buckles or, what do you call those things? Laces. That's right. All right, and if it's soft enough for you to fold into half and put in your pocket, those are no good for you. So shoes are important. Finally, eye condition. I had the opportunity to speak to people who had, it was a launch on AMD in our hospital, and eye condition is actually very important. Besides just the fact that you have contrast sensitivity problems when you get older, aging people do have cataracts, AMD and glaucoma. So these are some of the sights that you might see if you have any of those conditions, or my patients have any of those conditions. So in a nutshell, exercises, environmental modification, care of our eyes, for education, and most importantly, medications. A quick algorithm, and I'm going to end. This is something that, okay, any orthopedic colleagues here? Oh, hi. Okay, good. So the geriatricians and the orthopedic surgeons work in conjunction, okay? Can you imagine we are working together? It's so fun, right? And they came up with this really great algorithm, which I thought was actually useful because we're still following a lot of it. I would come to this part. Yeah, bring it all in for you now. I only come in when the patient comes to the hospital, right? And I'm right at the end of the food chain or the fall chain. But I think really for all of us here, I would really appreciate it if periodic case finding in the primary care, ask the patient about the falls in the last 1 year is really going to be important for us. And really people with no falls, I do encourage still a healthy lifestyle, exercises, lots of vitamin D, and that's the end.